transfusion. Transfusion is pretty simple stuff. Oh, sorry, I have a disclosure, but it doesn't involve anything I'm talking about here. So transfusion is pretty basic stuff. We have only 5 products that we release in general to the hospital. So it seems like it should be fairly simple what to give when. But if you're like me, you didn't receive any transfusion education when you were in medical school, or maybe you received an hour, and that was lost in between step 1 and step 2 and step 3. So when you got to the floor, your first day as an intern, you were expected to know how to order blood, and you might not know what the proper guidelines were. You usually can pick it up pretty quickly, but unfortunately sometimes it's picked up by someone who picked it up from someone who picked it up from someone, and so a lot of bad knowledge is passed down. So today I'll try and give a review of what evidence there is to base our guidelines on, and hopefully answer some questions. So we'll begin with red blood cells. The evidence that comes for red blood cell guidelines all comes from this one study. There was an original study called Transfusion in Critical Care, the TRIC study, in 1999, and that was done on critically ill patients in ICUs around the world. In 2007, they did a subgroup analysis on just the PEDS population, the PEDS cohort that was in the TRIC study. What the TRIP ICU did was it randomized, it was a prospective randomized trial, and it randomized the groups into a restrictive arm and a liberal arm. The restrictive arm received transfusions, The restrictive arm received transfusions when their hemoglobin was at 7 grams per deciliter. The liberal arm received transfusions if their hemoglobin dropped below 9.5 grams per deciliter. They're roughly equal cohorts. They're in 3 different age groups, below 28 days, 29 to 364 days, and then over 364. And these also were roughly equal. The primary outcome, these were critically ill patients, remember, so the primary outcome was death or multiple organ dysfunction. It was statistically a non-inferiority study, so if the 2 groups did just about as well, then they considered this a successful study. So all subjects began with a hemoglobin of 8, and not surprisingly, the restrictive group, who were supposed to only be transfused if their hemoglobin dropped below 7, 174 of these subjects received no transfusions. That's 54% of that cohort. Whereas the liberal group, only 7 subjects received no transfusions. So the liberal group received far more transfusions than the restrictive group. That's to be expected with these guidelines. But the outcomes were equivalent. The restrictive group, for new or progressive multiple organ dysfunction, there were 38 subjects who had multiple organ dysfunction in the restrictive group, and there were 39 subjects who had multiple organ dysfunction in the liberal group. No differences. For death, 14 and 14. So they are absolutely equivalent in the 2 groups. So the conclusion of the study was, in stable, critically ill children, a hemoglobin threshold of 7 grams per deciliter for red cell transfusions can decrease transfusion requirements without increasing adverse outcomes. That seems simple enough, but usually there are caveats. And in this one, the most important caveat is that second word, stable. These are only stable children. The protocol was temporarily suspended for active blood loss, surgery, severe hypoxemia, hemodynamic instability. In other words, anytime the patient started to crash, they gave them blood, no matter what their hemoglobin was. Now, that blood count was added to those figures I told you about, so still the restrictive arm received fewer transfusions than the liberal arm, but you always have to take that into account and when considering the study. Also, an important caveat is the average hemoglobin was not maintained at 7 or 9.5. It was at 8.7 and 10.8. So to say that these patients were safe at a hemoglobin of 7 versus 9.5, that isn't strictly true either, because most of the patients didn't even drop down to a hemoglobin of 7. They were maintained at a much higher level simply because they weren't bleeding. So I don't like to come away from this one piece of really good evidence that we have for red blood cell transfusions and say, written in stone, 7 is exactly the threshold we should be transfusing at. I don't think that's, you can draw that from this data. So the guidelines for AMPLATs are for stable children with no increased oxygen demand, transfuse at a hemoglobin of 9 grams per deciliter. If they're symptomatically anemic, if their hemoglobin is 13, it doesn't matter. Go ahead and transfuse them. But if they're stable, you don't have to just go by lab values. 9 is safe. 8 and 7 is probably safe too, but you can go ahead at 9 if you need to. For patients with cyanotic heart disease, 13 grams per deciliter, and for neonates, 13 grams per deciliter. Those numbers are based on nothing. I mean, there's no evidence to support them because no one's going to do a trial in these patients. So that's about all we have for red blood cells. So if you remember the number 9, we'll be very happy. Platelets, it becomes a lot more difficult because platelet trials, there are a lot more platelet trials out there, but the patients are infinitely confounded because the number of things that will consume platelets is endless, and it's hard to control for these things. But I think the very first study that I like was done by Cheryl Schlichter back in 1978. And this is a super simple trial. Remember, normal platelet count begins at 150,000, 150 to 400. What Dr. Schlichter did was every patient who came to the emergency department, she had a platelet count and took a guaiac of their stool. If they had no other reason for having bloody stool, she would put their data point on this curve. And what she found was that when their platelet count was 25, their guaiac was negative. 15, guaiac was negative. 10, negative. It was only when their platelet count dropped down to roughly 5 that you started to see spontaneous blood in the stool. That's pretty amazing that the body has such a high buffer, wide buffer, for platelets. So it was concluded from this study that a platelet count of 5,000 is sufficient to maintain vascular integrity. But nobody felt very safe with that number, and there's a good reason for that because approximately 7,000 platelets per day are consumed just to repair little holes that are constantly occurring in your microvasculature. So from these two numbers, they came away with the number of 10. 10,000 is the magic trigger for a prophylactic platelet transfusion. Once your patient drops below that, by all means, give them platelets. But all of the studies that have been done, and I'm not going to go through them today, I'll just go through one or two, have left us with a couple of central questions. What is the optimum prophylactic platelet dose to prevent thrombocytopenic bleeding? So these are normal patients where you keep them at 10. But what about patients who are febrile, patients who are septic, patients who have a consumptive coagulopathy, who have a hypersplenism? There's so many reasons why their platelets are going down more quickly than they should be, and are these patients going to bleed more quickly if you keep them at 10? I think everyone's scared of that sort of question. The second question is also central. Are prophylactic platelet transfusions superior to therapeutic platelet transfusions for the prevention and or control of thrombocytopenic bleeding? If therapeutic is equivalent to prophylactic, we don't have to give patients platelets anytime they drop below 10 or 20 or 30. You could wait till they start bleeding. But nobody knows the answer to that yet. And they're trying to find the answers. Oops. There are a couple of trials, or several trials, that are out there that tried to answer this question. The STOP trial tried to answer this question, and it was appropriately named because it was stopped early because there were too many adverse events. And that was in the US. I think it was in the US and Canada. The TOPS trial is currently ongoing in the UK and Europe, and they're only able to do this in the UK and Europe. They couldn't do this here in America. They are giving no prophylactic platelet transfusions and seeing if there's equivalent bleeding outcomes. So everyone in the transfusion world is anxiously awaiting the results of this trial to see if we can stop giving prophylactic platelet transfusions safely. Until then, we have to keep going. Oh, and Plato is a prophylactic platelet dose trial. It doesn't exactly answer this question. What Plato did was it said, right now, we have a bag of platelets, and in that bag, there's 3 by 10 to the 11 platelets in each bag, or roughly that amount. Can we give half that amount or double that amount and see a change in outcome? And the answer was no. We saw no changes in outcome if we have the dose or increase the dose. But I'll be talking about the Plato trial in a minute because there is a new outcome done on a subgroup analysis. So until we have more evidence, these are the guidelines that are available here at AMPLATS and across the river. If you have a non-bleeding, stable patient, 10,000. Give them platelets when they start dropping below 10,000. If they have mucosal bleeds, 20,000. If they have mucosal bleeds that are severe enough that they require a red blood cell transfusion, that is grade 3 bleeding by the WHO scale rather than grade 2 bleeding. And that is a platelet count of 30,000 where you start to give them platelets. Patients on anticoagulants, 30,000, although I see a lot of clinicians feel more comfortable at 50, and we don't really contest that because that's difficult. 50,000 is for active bleeding, invasive procedures, neonates, and 100,000 if you have any history of a head bleed and you're on ECMO or any other extracorporeal devices. These are all on those cards that we hand out, and in the back there are booklets with the latest edition just came out, so I left some in the back for the crowd, and if you want more, let me know, and I'll get you more. I brought up Plato because recently there's been a new finding in the pediatric population that I just wanted to let you know about if you haven't heard. So as I mentioned already, Plato looked at platelet dose and bleeding outcomes in patients with hyperproliferative thrombocytopenia. And they found that the platelet dose does not affect bleeding outcomes, as I mentioned. But 200 of the patients in the Plato study were pediatric. And when they analyzed this cohort separately, they got a very good publication in Blood that came out just recently. And that found that pediatric patients had a higher rate of bleeding when compared to adults. 88% of the children in the study had bleeding episodes compared to 67% in the adult cohort. And the most pronounced bleeding was in the autologous transplant population. Only 53% of adults had bleeding, whereas 93% of children aged 0 to 5 had bleeding episodes after autologous transplant. The article doesn't know why this is happening. I'm sure people are looking into that. But they came away with this conclusion. These data do not suggest that pediatric patients would benefit from a higher prophylactic platelet transfusion trigger than adults because the bleeding occurred over a wide range of morning counts. So some of the bleeding patients were at 10,000, some were at 50,000. But it does suggest that factors other than the platelet count are responsible for the higher incidence of bleeding in children. So this doesn't necessarily help you, but it lets you know that you're going to expect a lot more bleeding in these kids, and you might need to we might need to revisit the platelet policy for pediatric patients. Moving on to plasma. We recently made a dosage available for pediatric patients so that they get half a bag rather than a full bag to keep their volume a little bit smaller. In that bag, the volume is about 100 to 120 mils. There's 200 milligrams of fibrinogen and 1 unit per mil of all coag factors necessary to do the secondary hemostasis. Always keep in mind if you're doing a procedure and you're giving someone plasma that factor 7 has the shortest half-life. It's 4 to 6 hours once it's in the body. So if the procedure lasts for a long time and you need to be giving them plasma to keep them from oozing, you'll need to give them more plasma eventually. Dosage for plasma is the same as for adults, 10 to 20 mils per kg, and 2 units should increase factor levels by 20 to 30%. Now, plasma is way over-ordered. If you compare the number of units of plasma ordered in the States compared to Europe, we're over, I think, 1 or 2 logs higher, and our outcomes aren't that different. So I want everybody to keep in mind that in order to form a clot, you need only 30% of coag factors to form a clot. And when you're at 30% coag factors, your INR is somewhere down around 1.8 or 1.9. So the normal INR is 1.1 to 1.3, but your patient could be at 1.8, and they'll still be able to form a clot unless something else is going on. So the indications for plasma at AMPLATS are an INR greater than 1.8 or PTT greater than 45 seconds. And as I'll show you in a moment, plasma does not work very well unless the INR is greater than 1.8. And the higher the elevation of the INR, the more effective plasma is. This is a complicated looking graph, but it really is quite nice. On the x-axis, you have changes in the INR, and on the y-axis, you have the pre-transfusion INR. So let's look at this data point to understand this graph. This patient began with an INR before their transfusion of plasma of 2.5. After they got plasma, their change in INR was somewhere between -1 and -1.5. So they went from 2.5 to 1.5, thanks to an appropriate dosage of plasma. If you go down to the patients who started with an INR of 2, their change in INR was only, say, 0.7. If you go to the patients who have an INR of 1.5, and here's where we see most of our plasma orders at 1.5, the change is almost nothing. So plasma is useless. You're just pouring volume into your patients if you're giving them plasma if their INR is below 1.8. And the reason why is obvious once you think about it. The people who give plasma are normal donors like you and me with INRs of 1.1 or 1.2 in our plasma. So if you take a bag of 100 mils of 1.1 INR and pour it into a patient with full plasma volume, you're just diluting out those coag factors and having no effect. But if you have someone who is 1.8 or 1.9, that dilution will be significantly less and you'll have a greater effect. So if you only order plasma once they're above 1.8, you'll be doing your patient a favor. Of course, there's the vitamin K reversal of warfarin, but I imagine that doesn't happen much in PEDS patients. Cryoprecipitate is our easiest component. The volume is small. We pool about 5 to 10 units together for an effective dose. There's a lot of fibrinogen in each bag of cryo. In fact, there's only 5 things in cryo. Cryoprecipitate was named when they were looking for cures for hemophilia. They took a bag of plasma and they thawed it slowly, and they noticed that there was a slushy at the bottom. That was the factors, the coag factors that precipitated out at lower temperatures. And they eventually found that one of the factors that precipitated out was factor 8. Factor 8, there we go. And so it actually, cryo was originally called anti-hemophiliac factor. It still officially is called cryoprecipitate anti-hemophiliac factor. And so it only contains these 5 things, but because it contains so much fibrinogen in such a small volume, it's really effective in helping to form a clot because, as you all know, fibrinogen's at the very bottom of the coagulation cascade, and so you have to have the fibrinogen levels high enough to form a clot. So the main indications, really the only indications for cryo, are if your patient's bleeding, give them fibrinogen give them cryo rather if the fibrinogen count drops below 150, and if they're not bleeding, give it to them if their fibrinogen drops below 100. And that's it for cryo, so that's easy. Don't give it to them if they're hemophiliacs. Of course, we have synthesized factors for that. Granulocytes. Those aren't often ordered, and those of you who do order them, usually you probably know, you only order these when your patient is really at death's door, and they're the last gasp of hope for the patient. They are granulocytes. They're rich in neutrophils. There's some eosinophils, some basophils. And because we have trouble separating out the layers of the different components, there's also a lot of blood in there as well. So if you ever see a bag of grans, it looks pretty bloody. The criteria for granulocytes, the ANC has to be below 500. They have to be suffering from an infection that's refractory to normal therapy. So you had to have really exhausted all antibiotics, antifungals. It doesn't work so well for viruses because granulocytes, it's lymphocytes that target viruses, of course. And don't ever order these lightly because the Red Cross will call in special donors to donate grans. And these donors are given either steroids or Neupogen, or both, to increase their granulocyte count, just as we would do with a bone marrow transplant. It mobilizes the grans from the bone marrow into the peripheral blood, and then we add starch into the patient's bloodstream to separate out the red blood cells from the granulocyte layer so that it's easier to get a purified layer of grans. So it's no light thing for the donor. There's been no ill effect aside from headache that's been associated with this, but still, it's probably not a very nice thing. And lately, we've had a couple of orders of grants that have been canceled. Some of those orders have been canceled appropriately. The patient has recovered or the patient has died. But in one or two cases, not actually in the peds populations, the orders were canceled simply because they weren't well considered to begin with. And so we ask that you think about it hard before you order granulocytes. Just a couple of words on other things that we do to blood. All of our products here at Fairview are universally leukoreduced. That removes 90% of white blood cells from the components. It helps to prevent transfusion reactions. It also helps to prevent alloimmunization, which is important for our transplant population. Solid organ transplant mostly. So we don't worry about that. Irradiation seems to just create endless questions for us in the blood bank. Clinicians are often ordering irradiated products when they shouldn't, or not ordering irradiated products when they should. Irradiation is to deactivate lymphocytes. It doesn't kill them. It simply makes them unable to mount an immune response, to proliferate. So when you irradiate a component, a cellular component, you prevent transfusion-associated graft versus host disease. That is, I never like to say 100% because I'm sure there's a case or two out there where it didn't cause mortality, but it's usually universally fatal within 21 days of the transfusion. And there's an autopsy victim. It shuts down the bone marrow completely. So it's a really remarkable thing, and it's all about the CD8 cells. So the indication for irradiation, if you have a past, current, or scheduled stem cell transplant, you need to request irradiated products. If the patient has written on their chart stem cell transplant sometime in the future, that doesn't mean it needs to be irradiated. It's only if the checklist has begun to get them into bone marrow transplant or stem cell transplant. If they have any cancer, whether it's hematologic or solid organ, and we do that just for the pediatric population, there's no evidence to guide that whatsoever. It's just people are careful with peds. There is evidence that people with Hodgkin's lymphoma do need it, though. If they have a congenital immunodeficiency, particularly those that affect the CD8 cells. So if you have a patient with HIV that affects CD4, they don't need irradiated blood. If you have patients on steroids, they don't need irradiated blood. We do newborns up to 4 months, partially because their immune system may be immature, and partially because we may have undiagnosed congenital immunodeficiencies that we haven't caught yet. So that just is a safeguard. The only time irradiation isn't safe is when you have a pediatric patient that gets a massive transfusion, and there's going to be additional potassium in irradiated product because the irradiation causes the red blood cells to be a little more leaky. So there's a little bit more free potassium in the bag. And unfortunately, every year I'd say there's a case study or two published about a newbie that's given a massive transfusion and dies of cardiac arrest due to the excess potassium. So again, we don't want it ordered unless we have to. Transfusion risks. I always stress these because we don't want people to order transfusions unless they absolutely have to, and they can be broken down into two categories, the infectious and non-infectious risks. The infectious risks, as you can see from the numbers here, are very small. Back in the 80s, when HIV hit, blood banks became very, very safe places. We now have excellent tests for all of the standard diseases that are transmitted that can be transmitted in a transfusion. HIV is about 1 in 2 million. Hepatitis B is still the most frequent, although we've just developed a better test for it, so that will probably go down as well. Babesia, that's a real risk here in Minnesota because we're in Babesia Central, but it turns out that a lot of Babesia is transmitted in blood compared to these other diseases, but in general, the people who get it by a transfusion will develop a mild flu-like illness, and they don't even know that they've got Babesia. That's what the data shows so far. Bacteria, however, are a real problem. Platelets are stored at room temperature, and so if the donor had a mild illness or their skin wasn't cleaned appropriately, then that bacteria can grow up in the bag very easily. We do test every single platelet unit. The Red Cross does. They inoculate a couple of bags, to see if anything's going to grow up. But then that platelet is released to us, and it sits on our shelf for another 2 days. So there's always a chance, and the chance is greater with platelets. The non-infectious risks are more diffuse and sometimes harder to recognize. In some cases, they're severe, and in a lot of cases, they're not. The scariest, of course, is hemolysis associated with ABO incompatibility. And the only time that happens is when we have a clerical error. We haven't had that happen here at AMPLATS or UMMC in years, and we count ourselves lucky. But everyone I ask, keep on your guard just in case a nurse is really, really tired and forgets to do the bedside check. We're in the middle of a CMS mock trial, and someone did forget to do the bedside check. So we know it happens. Septic transfusion reaction, that's from the bacteria in the bag. Transfusion-related acute lung injury, or TRALI. That is the #1 cause of fatality of transfusion in the U.S., I think in Europe too. The statistics are 1 in 5,000 patients come down with TRALI after a transfusion, but we've never had a case here at UMMC or AMPLATS. Some people think it's because a lot of our patients are neutropenic, and the underlying pathophysiology of TRALI has to do with the neutrophils, but other people think it's just underreported or underrecognized. So I'd like you to listen up when I get to that part of the talk. And then there's TACO, which is transfusion-associated circulatory overload. Pathologists like food. Robin can tell you all about that. Allergic reactions, those are mild, but anaphylactic reactions are scary. And then there's febrile non-hemolytic transfusion reactions. Those usually don't amount to much, but they can make your patient end up in the ICU for a few days if it's severe enough. And then alloimmunization, which I'll talk about. So I'll go quickly through several of these. Acute hemolytic transfusion reaction, the most important thing is just to know the signs and symptoms. If your patient has a folian, the first sign is easy to see. It turns pink almost immediately, their urine. But if they don't have a folian, then they'll have fever and chills. That's the most common presenting symptom. They'll feel pain at the infusion site or in their back. They'll get kind of shocky. They might go into DIC. There'll be hemoglobinuria. Stop the transfusion immediately. Send the bag back. We'll do a clerical check and see if we've sent the patient the right bag. Septic transfusion reaction, a lot of the symptoms are similar. So again, as soon as you see a patient spike a fever or have pain, go into Rigers, have cramping, stop the transfusion immediately, and call the blood bank immediately, because a lot of times a donor has given 2 or 3 products. So it's bad that we've given your patient septic transfusion reaction, but it'll be even worse if we don't have time to quarantine off those other co-components and save another patient from a septic transfusion reaction. And these do kill people. Every year there's 1 or 2 deaths reported from septic transfusion reactions. TRALI, as I've already said, is the #1 cause of transfusion-related fatality in the U.S. There were about 40 cases last year reported. We had 1 case reported from UMMC that ended up being a TACO, but the patient did die. It's acute lung injury within 6 hours of a transfusion. The patient becomes hypoxic. They have bilateral pleural infiltrates. It used to be that plasma was the most frequent cause, and then thanks to a trial that was begun in Europe, it was noted that multiparous women giving plasma transfusions were usually the cause of TRALI. And it turned out that the antibodies that they had in their plasma were attacking the neutrophils and lymphocytes sometimes in the lungs of the recipient, and that's what causes TRALI. The neutrophils would start to release cytokines. It would make the vasculature leaky, and the patients would come down with a pleural effusion very, very rapidly. The only support, unfortunately, for TRALI is giving O2. Diuresis doesn't work. So you just have to support them through this. Recognize and support them through this. I like showing this slide because it's very dramatic. This patient had just had a lung transplant, a unilateral lung transplant. Then they were given a plasma transfusion and had TRALI in just 1 lung. So you get a complete whiteout within 6 hours. So it's very dramatic when it does happen. The problem with TRALI is that it's often confused for TACO, transfusion-associated circulatory overload. Very difficult to distinguish, but if you give them a pressor, they will begin to diurese with TACO. So TACO occurs in any patient who has other reasons for circulatory overload. They have heart problems. That doesn't happen as often with children, but I imagine children can be volume overloaded pretty quickly. The patient who died here due to TACO, she had a platelet count of 18, and the doc decided to just tank her up before sending her out the door. So he gave her a unit of platelets, and that just sent her over the edge. And she was DNR, DNI, and she was an elderly patient, not too elderly though. She was in her late 60s, and she died. So don't tank up. Don't give if you don't have to, please. Anaphylactic transfusion reactions are rare, but they do happen. We just had one on the unit the other day. Usually the patient is IgA deficient, and they have antibodies against IgA, and as soon as they get a few drops of a component in them, they go completely anaphylactic. It's scary, but they respond well to an EpiPen. And I think that's all I wrote about. Febrile reactions, the patient will spike a temperature. You have to stop the reaction. I hate saying that to people, especially the bone marrow transplant kids, because they're spiking fevers all the time. But if it's something worse, you have to, because there could be a septic transfusion reaction instead of just a febrile reaction, which is just a bunch of cytokines causing a fever in the patient. But transfusion reactions, what to do. I'm a pathologist, so I always feel a little silly talking to clinicians and telling them what to do. It's just supportive measures. Report the reaction. Return the bag and the tubing to the blood bank. Draw blood for cultures before administering antibiotics, and page the transfusion MD. The nurses know the drill. They know the drill really well. But in July of every year, we end up with a bunch of people calling the blood bank, not knowing what to do, and continuing the transfusion. The transfusion risk of alloimmunization becomes very real when we have a patient who's waiting for a kidney and they have so many antibodies, we just can't find them a compatible kidney. Red blood cells, of course, are coated with surface antigens. They're shown here. There's ABO, which everyone knows about. There's RH, which everyone knows about. But then there are dozens and even hundreds of others that can cause an antibody that make it more difficult for us to find compatible blood for that patient. Platelets are coated with class 1 HLA, and that can cause a lot of problems, as I said, with the solid organ transplant population. So again, give a transfusion if it's needed, but don't if it's not. And the final topic for the day is Massive Transfusion Protocol and emergency release. This causes a lot of confusion in the hospital. The PICU pretty much has it down, but every once in a while there still is a problem. An MTP, Massive Transfusion Protocol, is defined as the replacement of patient's blood volume within 24 hours. If a patient needs more than 4 units of red blood cells within an hour, they probably need an MTP. It's one of those things where it's hard to define, but you know it when you see it. To start an MTP, it's easy. Just call the blood bank. It's all verbal. There are no orders in Epic that need to be added at all. At the end, we'd like you to tell us what happened by putting a note into Epic, but we don't want to slow things down for you. So if a patient has an up-to-date type and screen, and we hope they do if you think that blood is going to be necessary for this patient, then we'll provide coolers that have 4 red blood cells, type specific, 4 plasma, and 1 platelet. We'll continue to produce coolers endlessly until you tell us to stop. The first cooler takes us about 30 minutes to put together. We're actually going to get that number down to about 15 minutes soon because we're changing some policies, but I won't go into that now. Each subsequent cooler will usually take about 15 minutes. The blood bank will call the floor when each cooler is ready. Send a runner to the blood bank with a completed release form when you're ready to get the cooler, or just a patient label will be sufficient, but we prefer a completed release form. Again, the nurses usually know to go into Forms on Demand to get that release form. If there's no current type and screen in Epic, then the first cooler is going to take longer because we want to be able to start getting you compatible blood. But if you need the blood stat, then you just ask for emergency release. So these are 2 separate things. There's an MTP, which is invoked a lot In non-emergent cases where they just know that they're going to need lots of blood, they've just hit a major vessel, or there's a lacerated liver, or there are endless reasons why it might not be emergent, but they need a lot of blood. But in cases where it is emergent, every single person who calls in for an MTP, the first thing the blood bank says back to them is, do you need 2 emergency units? And at that time you could say yes, and we may need more. So emergency units are not cross-match compatible units. They're own eggs, and if your patient has antibodies, there could be a problem, but probably the anemia is more important. They're going to be available within 5-10 minutes from the blood bank. They need to be signed for by the ordering MD because there is risk that is associated with non-cross-match compatible units. It's non-irradiated units as well, because we're trying to get the blood out the door as quickly as possible. One key to success for an MTP is that only one team member should be the coordinator between the blood bank and the floor. Sometimes in the panic-stricken moments, first moments of an MTP, there are a lot of people calling the blood bank. This happens in a lot of units, and it just slows us down. We might have 2 techs working at night, and they're both on the phone answering questions about the MTP when they need to be getting the blood together. So assign one person. Down at Southdale, they actually make someone wear a little red hat, and that's the person. We're not going to ask anyone to do that here, but we want each unit to come up with a plan so that whether it be the charge nurse or someone who is always going to be the designee to coordinate the blood bank, going back and forth with the blood bank, because you guys call the blood bank, but we're also the MD who may be at home, the blood bank MD, will also be calling the floor, trying to coordinate special needs and explaining risks and possibly suggesting tests to keep the MTP going smoothly. I'm going to end on just a little bit of data. We audit 100% of red blood cell transfusions in the hospital. We do that in a semi-automated fashion using just lab numbers. We don't have time. We have 1,000 red blood cell transfusions a month in the hospital, so we don't have time to go into each chart and see if it looks appropriate. So if the hemoglobin is below 9, we say this is automatically appropriate. The hemoglobin's above 9, if it looks as though it's been going down slowly or the patient is obviously bleeding from lab values, then that's also appropriate. But the PEDS group does excellent. And as I said in the beginning of my talk, we monitor this very closely. Blue Cross Blue Shield has a program with Fairview that if we meet certain metrics, we get a big break on insurance or money. I don't know the details, but I know that it makes people get very nervous if we start dropping below the numbers that are the targets for Blue Cross Blue Shield. And so the other month, for the very first time, the PEDS group slipped a little bit, and I started getting a lot of phone calls from Blue Cross Blue Shield and other groups in the hospital. So the slippage wasn't real. The next month, you were up even higher. But here's the data. I don't think you're going to be able to read this from the back, but the blue bars are the appropriate units, and the red bars are the inappropriate units. And these are all pediatric transfusions for the month of July, separated by the various specialties in the hospital, the emergency room, cardiology, ICU. Because it was so small, I put the real numbers here. And as you can see, you're doing an excellent job. Really, really excellent job. The few times where it looks as though you're dropping significantly below 100% appropriate, it's because there are very few units that have been given, so that can be skewed very easily. And again, some of these numbers are possibly wrong because we're not going into the charts and looking. So other services that are doing poorly, we send reports out each month so that the medical directors of that service line can look at these numbers and contest them. But because PEDS does so well, we don't bother with that. But if you're interested in contesting these numbers, I could look at it for you. But that's all I've got for today. I want to thank you for your attention. We're always available for questions, and please take a book from the back. Anyone have any questions?
Just talk about how the numbers that you suggested for platelets or for plasma transfusion might vary depending on the etiology of the thrombocytopenia or the etiology of the coagulation.
That's a difficult question to answer.
I guess my point is I wouldn't think of them as being strict guidelines in someone who has a consumptive thrombocytopenia.
No, they're not. They're not. That's about as good as far as I can say. If they have consumptive coagulopathy, usually there are signs and symptoms of that consumptive coagulopathy. Mucosal bleeding, for instance, if they drop below a certain amount. We work very closely on the adult side with the bone marrow transplant unit and the hem-onc unit, looking at the patients and saying, okay, you've triggered them at 50, but these signs and symptoms have gone away. You no longer need this. It's from what I've seen. Once a patient begins to bleed, it's hard to make them stop. So you want to keep the platelet count high enough to make sure that doesn't happen. If they have a consumptive coagulopathy, are you seeing signs that they're bleeding? Or because if they're actively bleeding, certainly keep them above 50. Am I answering your question?
Sort of. I mean, there's always this discussion like with TTP, for instance, adding platelets or fueling the fire.
Yeah.
Everyone says that. So I guess my point is just to make for the residents that those numbers don't apply in all of this.
No. So
Thrombocytopenic phase.
no, TTP is the one absolute contraindication to a platelet transfusion because, as you said, you're feeding fuel to the fire. If a TTPer starts to bleed, they don't often, but if they do start to bleed, we will give them platelets because we're hoping that will stop the bleed. But it's a bad scene, basically, when they do start to bleed. ITP, in my experience, they don't bleed. I've seen ITPers at 0, and they just don't bleed, and I can't really explain that. It's interesting. DIC, of course, you just have to get at the root cause of the DIC to stop it, but give them platelets as necessary. They're going to be consuming, but they also are thrombosing, so it's a risk. No matter what you do, it's a risk, and it's very, very difficult to get at the right number. We ask you to not chase the count, which is, it used to be that people were ordering platelet count after platelet count after platelet count to see if their patients were at an appropriate number, and then that would lead to more platelet transfusions. If there's no sign of bleeding, don't give platelets, but if you're worried because there is some ongoing process, monitor them as closely as you need to and give them platelets to keep the bleeding from happening. Certainly keep them above 10, and if you're worried about bleeding, above 50. Yeah.
Question, just one for maybe clarification. I'm not a pediatric hematologist or bone marrow transplant docs, but when you say ITP patients don't bleed, I think maybe you meant to say they don't typically have catastrophic life-threatening bleeding, but just so residents know, I mean, if you see a patient with mucocutaneous bleeding, that absolutely fits the syndrome of ITP.
Yeah, yes, I'm sorry.
And
Yes.
the second question is, for the indications for radiation or radiating a blood product, is not directed donorship from a family member
Yes.
an indication?
It is, and I didn't mention that because the blood bank takes care of that for you. The reasons for that are kind of cool. In most cases, if you are immunosuppressed so that your CD8 count is low enough that they can't meet the challenge of the lymphocytes. So let me back up. Transfusion-associated GVHD occurs because the lymphocytes in the bag recognize the patient as foreign and attack the patient. In an immunocompetent patient, they can stave off that attack. Immunosuppressed patient, they can't, and they'll succumb to TA-GVHD, except in cases where they're related. And that's because if your patient is homozygous for an HLA site, a loci, they may look at the lymphocytes in the bag and say, oh, you're just like me. I'm not going to attack you. But the lymphocytes in the bag might be heterozygote for that site. So I'll take the B locus. Let's say your patient is homozygous for B27. So they have 2 alleles for B27. Am I saying this right, or am I getting it backwards?
There can be unidirectional
It's the opposite. If your patient is B27, B35, and the patient, no, I had it right. The patient, anyway, sorry, it's confusing. The point is the patient will not fight off the lymphocytes in the bag, and so TA-GVHD occurs if they're highly related. They noticed this first in Japan, where patients were dying left and right due to transfusions because they're so homogeneous there. So even though they're not all related, their HLA is similar enough that there is a lot of TA-GVHD. So there's universal irradiation in Japan. So when we have directed donors coming in and giving transfusions, we make sure to irradiate those to prevent this from happening. So we take care. That's why I didn't mention it. We take care of it for you. Yeah.
When we were on the other campus, I used to get calls frequently from the blood bank for GI patients needing irradiated blood because we share the same floor as the hemo patients. Is that the same policy here?
No. No.
Okay. They just wouldn't let unirradiated blood onto the floor.
Really? That's bizarre. Now, we had 11 near misses about 7 years ago. And this was before I came on board. There was a big overhaul. And it's a now much safer process. But probably that was a repercussion of that.
But I just
Yeah.
had to order it before you were
No.
Are we giving kids fresher red cells? Is that
We're giving, in general, no, we're giving neonates fresher red cells. There is no evidence yet that fresher red cells are better than older red cells. So red cells can be stored up to 42 days. And the one thing that has been documented is that their 2,3 DPG goes down in the bag, but as soon as you transfuse them, within 24 hours, that 2,3 DPG level goes back up. And if, to remind you of your freshman year in medical school, 2,3 DPG allows the hemoglobin to hold on to the oxygen more tightly. So there's no good evidence in the literature yet that fresher cells are better. The only case where it may be true is, the only other thing that happens is red cells become less able to deform as they get older. So as they crawl through the microvasculature, older red cells are going to have more trouble than younger red cells. So ICU docs are really, really want the younger red cells. We don't have a policy yet because, as I said, the evidence isn't strong yet. But yeah, that's all I'm going to say because we don't release younger cells. Sicklers, who are going to be prone to have trouble with their microvasculature, and neonates get it. Anything else? Yeah.
There was one of the residents. There was a case last year where had a fever prior to a transfusion, and then we gave a transfusion, and the temperature went up like 1 degree Fahrenheit. And I believe, if I remember correctly, we were told that's okay as long as it's involved by accident.
Yeah. The official guidelines are 2 degrees Fahrenheit or 1 degree centigrade temperature rise in order to start worrying. Because in septic reactions, it tends to be significant. But if your patient is on Tylenol or something, then that's going to mask it. So I worry. Thank you. Was it fun? Did I confuse everyone with the THEVHD?
No.
No.
I
I
mean,
always